Welcome to The Explainer. Today, we're stepping right into the hot seat of a surgical board exam, the viva. This is it, the final hurdle. We're going to tackle a classic high-stakes case, the patient with obstructive jaundice. We'll break down the questions, the answers that get you a pass, and, most importantly, the consultant-level thinking that truly makes you stand out.
Okay, let's begin. Let's dive right into this case. The clock's ticking. Now, this isn't a trick question, but it's absolutely designed to see how you think under pressure. Your answer from the very first word needs to show a structured, safe, and systematic approach. Sir, I'd proceed with a structured approach. First, I'd start with a detailed history and a thorough physical examination. From there, I'd move on to investigations to help me formulate a differential diagnosis. Then, critically, I would grade the severity of her condition to guide both the immediate and definitive management plan. And throughout this whole process, I'd be remaining vigilant for any complications. Very good. That's a solid framework. Now, let's build on that. What are the absolute key points you need to get from this patient's history?
I would really focus on the jaundice itself. When did it start? How long has it been there? Is it getting worse? I'd ask about those classic signs of obstruction, like pale stools and dark urine. Then I'd move on to associated symptoms. Is there pain, a fever? These can point me towards stones versus something more sinister. I'd also need to screen for red flags, things like weight loss and night sweats. And of course, I'd dig into risk factors for biliary disease and ask if she's ever had attacks like this before.
Good, you've gathered this story. Now, what are you looking for when you actually examine the patient? My exam will be a full head-to-toe, starting with her general appearance and vital signs. I'll pay close attention to her hands and eyes, looking for any stigmata of liver disease. Then, a really thorough abdominal exam is key. I'll inspect for any scars or distension. I'll palpate for any tenderness, especially in the right upper quadrant, or any masses. And of course, I'll specifically try to elicit a Murphy sign.
Excellent. A really comprehensive approach. So based on your initial findings, what's your differential diagnosis?
I'd categorize my differential into 3 big buckets: prehepatic, hepatic, and posthepatic causes. Now, given the presentation, my suspicion is definitely leaning towards a posthepatic or obstructive cause, and this table illustrates those categories really well.
Okay, so the initial imaging supports your suspicion. Let's get specific, candidate. How do you make a definitive diagnosis?
According to the Tokyo guidelines, a definitive diagnosis requires a combination of findings: one local sign of inflammation, like a positive Murphy sign, one systemic sign, like a fever or raised white cell count, and of course, confirmatory imaging findings.
Correct. Now that you have a diagnosis, how do you assess the severity and start your management? This is absolutely critical. I would grade the severity based on the presence of any organ dysfunction. So grade 3 is severe disease with clear organ dysfunction. Grade 2 is moderate, and grade 1 is mild cholecystitis in a patient who is otherwise healthy. Yeah, and regardless of the grade, the immediate management is all about supportive care. That means getting IV fluids in, getting on top of the pain with analgesia, and starting the right antibiotics. Okay, so you've stabilized her. What's the definitive management plan for this patient? Well, the evidence-based guidelines are very clear here. They strongly recommend an early laparoscopic cholecystectomy, ideally happening pretty soon after the symptoms start. So the crucial point is that for patients who are stable enough for surgery, this is the definitive treatment. It's the gold standard. Your plan is sound, but let's change the scenario. Right before surgery, the patient suddenly gets much sicker. She's now febrile and her blood pressure is dropping. What is your immediate concern? My immediate concern, without a doubt, is the development of acute cholangitis. That's a life-threatening infection of the biliary system. This is a true surgical emergency. I would immediately start resuscitation following the ABC protocol. Secure the airway, give oxygen, and get 2 large cannulas in to start aggressive IV fluids and draw blood cultures. Then, get broad-spectrum antibiotics on board and get the ICU involved right away. After we've stabilized her, the definitive management is urgent decompression of the biliary system. The most common way we do this is with an ERCP. One final question, candidate. The gallbladder has been removed. What are you looking for on that histology report that you absolutely cannot afford to miss? This is what separates the consultant from the resident. What is that never miss diagnosis?